We are joined by the Acting Director of the Africa CDC, Dr. Ahmed Ogwell, who is going to take us through that briefing on the situation of pandemics. Today, he's also going to be updating us. And that update is going to be on the progress that is being noted on the implementation of the Saving Lives and Saving Livelihoods initiative. We have a number of countries that have started implementing, and we also have quite a number that have indicated their intention to start implementing and launching this very important campaign. So today, I just want to announce that we don't have interpretation, so all our communication is going to be in English. And if you want to send in your questions, please use the WhatsApp number +251 94 550 2310. That number again, it is +251 94 550 2310. But we can also interact with you live on this platform as well as through the question and answer section. So our flow of the program today is going to be as usual. Dr. Ahmed will give us a breakdown of the situation of pandemics on the continent. And then after that, we will then go into our question and answer section. All right, it is now time for me to hand over and bring in the Acting Director of the Africa CDC, Dr. Ahmed Ogwell. Bye-bye. Let's meet during the question and answer section. Dr. Ogwell, it's over to you.
No, thank you. Thank you very much, Wayne, and our colleagues, wherever you're joining. Good morning, good afternoon, good evening, and welcome to this update today from the Africa CDC. And as usual, I'll start with the COVID-19 updates. As of today, the 25th of August, we in Africa have recorded 12,037,379 COVID-19 cases, which is 3% of the total cases of COVID-19 reported globally. We have also experienced a recovery rate of 95%, with 11,409,760 individuals recovering from COVID-19. Unfortunately, we have lost 255,543 individuals, which gives us a cumulative case fatality rate of 2.1%. And this number also accounts for 4.1% of the total number of deaths attributed to COVID-19 globally. The top 5 countries, which give us a total of 61% of the cases, remain the same here in Africa, with South Africa contributing 33%, Morocco 11%, Tunisia 9%, Egypt and Libya each at 4%. During this week, 40 countries are reporting a case fatality rate that is higher than the global average of 1.1%. And this still remains a concern for us here in Africa, that our case fatality rate is still higher than the global average. Indeed, the same 2 countries, Somalia and Sudan, are still reporting a case fatality rate higher than 5%. And I may add that this particular rate stays a little bit high because the numbers are going down, and therefore the equalization will not be as rapid as when we were seeing the higher number of cases earlier on in the pandemic. Fifth wave has been experienced by 27 member states, the same as last time. There's been no change. And the sixth wave has been experienced by 5 member states. Again, there is no change from last time. And before our colleagues from Kenya do ask, we can now comfortably say that Kenya has transitioned out of the sixth wave, considering the numbers that we are seeing and the sustainably low rates, both at infection and testing that has been reported over the last 10 to 14 days. When we look at the variants of concern here on the continent, again, the list that we gave remains the same, but I must add a few pointers. One is that to date, we have sequenced 115,080 sequences. That is 115,080 sequences since the beginning of the pandemic, and this comes from 53 of our member states. Second important point is that 29 of our member states have reported the Omicron BA2 sublineage, while 17 have reported the Omicron BA4 sublineage. 13 have reported the Omicron BA5 sublineage, and the most recent that happened during the week is Omicron BA275 sublineage has been reported. One case has been reported in South Africa. We continue to monitor very closely that case so that we do not get surprised by the BA275 sublineage, which seems to be spreading quite rapidly elsewhere in the world. So I repeat, the Omicron BA275 sublineage has been documented here in Africa, in South Africa, and we continue to monitor very closely through sequencing for the situation on the continent. Let's look at the one-week trend. Epidemiological week 33, which was the 15th to the 21st of August, 2022, and we are comparing that to epidemiological week 32, which was 8th to 14th of August. During that one-week trend, during that one-week period, the trend is as follows. A total of 7,807 new cases have been reported here on the continent, and this corresponds to a 38% decrease in the number of new cases when compared to the previous week. The highest proportions were seen from the Southern Africa region with 35%. Northern Africa region had 28%, Western 16%, Eastern 13%, and the Central Africa region 8%. When we look at the data in terms of countries, the following reported the highest number of cases. South Africa, 1,566, Algeria with 668, Tunisia with 638, Morocco with 532, and Burundi with 515. When we look at the highest daily incidence per million population, Seychelles reported 229 cases per million population, Namibia 21, Sao Tome and Principe 10, Cabo Verde 9, and Tunisia 8. New deaths during this EP week 33, we saw a total of 38 of the new deaths, and this represents a 77% decrease when compared to EP week 32. When we look at a 4-week trend from the 25th of July to the 21st of August, the number of new cases decreased by 31%. When we look at that breakdown per region, we see that there was a 5% increase in the Eastern Africa region, 43% decrease in Northern region, 20% decrease in central region, 16% decrease in western, and 11% decrease in the southern region. When we look at it from the most populous countries' perspective, Kenya reported a 33% average decrease. Ethiopia, 25% decrease. DRC, 22% decrease. Nigeria, 6% decrease. South Africa, 5% decrease. And there was no change in Egypt. New deaths over this 4-week period. We have seen an overall 20% average decrease in the number of new deaths being reported on the continent. By region, we see a 91% increase in the Southern Africa region, 72% increase in Eastern, 3% increase in Western, 37% decrease in Northern, and a 4% decrease in the Central African region. By most populous country, Kenya documented an average of 100% decrease, Ethiopia 70% decrease, South Africa 48% decrease, and there was no change in DRC, Egypt, and Nigeria. Looking at the tests on the continent to date, we have conducted over 121 million COVID tests in all our African Union member states since the pandemic started. And we have seen that over 400,000 new tests were reported during this epidemiological week 33. And this is a 61% decrease from the previous week when we had over 1 million tests being done. For this week, Epi Week 33, the positivity rate is 2%, while the test per case ratio is 52 across the continent. And this represents an increase by 58% in the positivity rate and a decrease by 37% in the test per case ratio compared to Epi Week 32. Only one country continues to report a test positivity rate of which is higher than 12% during this week, and that is Libya. When we look at vaccination for COVID-19 across the continent, as of the 24th of August, this is the situation. 929 million COVID-19 vaccine doses have been supplied to the African continent. And this, you will realize, is a slight decrease from the figure that we gave last week. And this is as a result of data cleaning and rationalization with the discrepancies we are seeing from country level. And so the correct figure as of 24th of August is 929 million COVID-19 doses that have been supplied to the continent of Africa. Of these, 671 million COVID-19 vaccine doses have been administered, and that corresponds to 72% of the total supplies here on the continent. When we look at coverage, now it stands at 22% for those who are fully vaccinated on the continent. And the same 10 countries are still giving us the figures above 40%. Of note is that for Sao Tome and Principe, we are now at 44.8%, which is an increase from last week. And Mozambique is at 44.2%, which is an increase from last week. Otherwise, the same countries, Seychelles, Mauritius, Rwanda, Morocco, Botswana, Cabo Verde, Tunisia, Sao Tome and Principe, Mozambique, and Liberia are the 10 countries reporting vaccination rates that are higher than 40% here on the continent. Looking at deliveries by the Africa Vaccines Acquisition Trust, which is an initiative of the African Union, as of the 24th of August, 74,911,000 2,900 doses of Johnson & Johnson vaccine have been delivered to 35 of our member states. The breakdown for this is those that have been procured by member states themselves through the Africa Union are 49,656,000, while those that have been procured through the Saving Lives and Livelihoods Initiative with support from the Mastercard Foundation are 17,899,200 doses, while the US government has donated 7,356,700 vaccine doses. It is worthwhile to share with you here the progress that we have made when it comes to the Saving Lives and Livelihoods Initiative, which is our way of pushing up vaccination rates here on the continent. And to date, of the 55 member states, we have engaged with 49 to begin planning and implementing the Saving Lives and Livelihoods program, which is a mass vaccination campaign for COVID-19. So we have engaged with 49 of the 55, while 34 have actually completed the planning process, and 19 we have actually gone into actual implementation, and we are at different stages, as I will share at the moment. We rolled out the mass vaccination campaign in June of this year, and since then, we have 6 of our member states that are actively implementing the mass vaccination campaign under the Saving Lives and Livelihoods initiative, and these are Ethiopia, Kenya, Nigeria, Rwanda, Namibia, and Lesotho. Our aim is that each and every country reaches 70% of its population being fully vaccinated. So we are actively in these 6 countries. Now, this is out of the 19. The other 13, we are going to go in a stepwise fashion until we complete all 49 countries that have joined the initiative. The results that we see from the countries that are implementing are very encouraging. We have seen increased vaccination rates in Ethiopia, particularly the areas that the Saving Lives and Livelihoods initiative is covering. We've seen increased vaccination rates in Kenya, and indeed, we have also seen increased vaccination rates in Nigeria and Namibia. And Namibia was the latest countries that we launched the mass vaccination campaigns last week. The countries that we are going into next include Botswana, Burundi, Malawi, and Zambia, and these will be done over the next 1 week. Within the next 3 weeks, we will then transition into Tanzania, Uganda, Togo, Djibouti, Comoros, Burkina Faso, Gabon, and Sierra Leone, so that we can complete the 19 countries whose plans have already been approved and everything is established to begin mass vaccination campaigns. We are doing these campaigns in 2 ways, depending on a country's preference. Either we do mass vaccination campaigns only, or we do mass vaccination campaigns and combine that with integrating COVID-19 vaccination into the national vaccination program. In fact, in the second week of September, we are going to be having a continental meeting of senior staff from all ministries of health, those who are responsible for the expanded programs of immunization, so that we can see how to integrate COVID-19 more formally in all countries on the continent. Let's move now to updates from other disease threats on the continent, and today I will share 6. There are many more, but some are at smaller scales, and as I've explained before, I'll only be covering the ones that are raising concerns for us from different angles. And I will start with monkeypox. Since the last brief, 219 new cases, that is 219 new cases have been reported, including 48 that are confirmed and 171 that are suspected. These were reported in the DRC and Nigeria over the last 1 week. No new deaths have been documented. This number of new cases represents a 54% increase in the number of new confirmed cases compared to those that we reported last week. DRC has reported 114 new suspected cases and no new deaths, while Nigeria has reported 105 new cases, including 48 confirmed and 57 suspected, with no new deaths. The difference in the fact that Nigeria is confirming some cases is due to laboratory capacity, including the availability of test kits for monkeypox. Cumulatively, the whole of this year, 2022, we have documented 3,451 cases, including 459 confirmed and 2,992 suspected, with 105 deaths, which gives us a cumulative case fatality rate of 3% in 11 member states of the African Union. As Africa CDC, we continue to do three key things. One is strengthen different countries' capacities for disease surveillance so that they can identify any case early before it becomes a community problem. Second is we are building the capacities of the different countries for laboratory diagnosis and providing test kits so that they can be able to make confirmations of cases. We have not yet begun vaccination. Outbreak I would like to share is the one for virus, a disease in the DRC. And we see that on the 17th of August, the Ministry of Health of the DRC reported one confirmed case of Ebola virus disease in the Beni district in North Kivu province. This case was confirmed 6 weeks after the most recent Ebola virus disease outbreak in the Equator province was declared finished. Results from genomic sequencing reveals that the current case is actually linked to the 2018-2020 Ebola virus disease outbreak that occurred in the same province. And as Africa CDC, we have engaged with the government, and apart from initiating rapid needs assessment and rapid response, we are also supporting the government to carefully study what has led to this situation of the same variant that we thought we had arrested since 2020, popping up in the same population about 2 years later. We want to understand where the reservoir may be so that we can be able to stop further outbreaks across the country and the continent. We are recommending to countries, especially those in close contact with DRC, either directly or by travel and trade, that countries need to enhance their cross-border surveillance so that any suspected case can be able to be picked up quickly. We are also encouraging countries to integrate their surveillance systems for Ebola virus disease into their regular surveillance strategies. That way, we don't wait for an outbreak to be on the lookout. We pick the cases as they come. We're also encouraging countries, whenever a case is identified, a very urgent and quick action is taken to track and trace all possible contacts to be able to contain Ebola virus disease quickly. We are also encouraging countries to enhance their infection prevention and control measures, particularly at health centers where a case will most probably be presenting fast. We are also encouraging our governments to engage with community leaders because there are other mechanisms in place for healthcare in many African communities, and we want to be sure that those other mechanisms are also prepared for any situation like the one that we have seen now in the DRC. Third, on the 14th of August, the Ministry of Health in Kenya reported an outbreak of influenza A, which is H1N1, in one part of the country called Nakuru County. A total of 143 cases, including 5 confirmed and 138 suspected, with 1 death, which gives us a case fatality rate of 0.6%, has been reported in that particular area of Kenya. 88% of the cases are among children under 5 years. In response, we have deployed a rapid team to support the Ministry of Health in Kenya in ensuring active case search, sample collection, and necessary countermeasures, both at the health facility level and at the community level as well. We continue to monitor this situation very closely within the Eastern Africa region because of the ease of travel across that particular region. The fourth is Crimean Congo hemorrhagic fever in Senegal. This particular situation we have seen in only one country so far. And on the 15th of August, the Senegalese Ministry of Health reported this outbreak in one of the regions. And cumulatively, we have seen 2 confirmed cases and 1 death, giving us a case fatality rate of 50%. Currently, we are supporting the Ministry of Health in Senegal to do very active case search so that we do not leave out any cases unattended to ensure that we stop the spread of Crimean Congo hemorrhagic fever in Senegal. Fifth is Lassa fever. And this is in multiple countries across the continent. Since the last brief, 194 new cases and 4 deaths of Lassa fever have been reported in Guinea and Nigeria. This represents a 6% increase in the number of new cases compared to the last brief. And for Guinea, they have reported 7 new cases, including 6 confirmed and 1 probable, with 1 new death, which gives us a case fatality rate of 14% in Guinea for this past week. Nigeria has reported 187 new cases, including 9 confirmed and 178 suspected, with 3 new deaths, giving us a case fatality rate during the week of 1.6% from Lassa fever. Cumulatively, since the beginning of the year, the continent has documented 7,349 cases, including 950 confirmed and 6,399 suspected, with 194 deaths, giving us a case fatality rate of 2.6% across 7 member states on the continent. We continue to provide support in terms of capacity building, test kits, and countermeasures to all the countries affected. Finally is cholera, a multi-country outbreak that we have seen in 13 countries so far. Since the last brief, we have documented 633 new cases and 9 deaths, giving us a case fatality rate for the week of 1.4%. And these are largely reported from Cameroon and the DRC. And this represents a 40% decrease in the number of new cases of cholera compared to the last brief that we had. Cameroon has reported 187 new cases, including 25 that are confirmed and 162 suspected. 4 new deaths, giving Cameroon for this week a case fatality rate of 2.9%. while in the DRC, we have reported 446 new confirmed cases with 5 new deaths, giving the DRC 1.1% case fatality rate for this week. Cumulatively, since the beginning of the year, we have seen 34,692 cases of cholera, including 3,155 confirmed and 31,537 suspected, with 500 deaths, giving us a 1.4% case fatality rate cumulatively in 13 member states during this year. We continue to provide countermeasures and field support to the affected ministries of health across the continent for bringing this cholera outbreak under control. Let me add finally that this is the week when the WHO African region is holding its regional committee, where health ministers from its 47 countries meeting in Lome. Africa CDC participated actively earlier in the week, and we continue to provide support to these very important governance meetings of the WHO, as well as those of the Africa CDC and the Africa Union, because health security remains a very top agenda for all institutions that are dealing with public health. Thank you very much, and back to you, Wade.
Thank you very much, Ahmed, for that briefing. And colleagues, thank you for joining us. I want to give you that WhatsApp number for your questions. It is +251 94 550 2310. We are, in fact, still waiting for your questions to come up. So please feel free to utilize either that WhatsApp number or the platforms available on this Zoom platform that we're using. And in fact, as I am speaking, I see that one hand has gone up. And that is Sarah Jerving from Devitz. Sarah, good morning. Please go ahead with your question.
Good morning. Thank you so much for taking my question. I'm wondering if you can talk about the highlights of the meetings, the WHO meetings, what have been the big takeaways this week so far? And then if you could comment on the health crisis in Somalia due to the drought. What are you seeing on the ground there? Thank you.
Thank you. Thank you very much, Sarah, for the regional committee meeting for the Afro region of WHO. There's nothing specific I can be able to give here because the meeting is not finished. It goes on until tomorrow. And I am very confident that the Regional Office for Africa will be providing key highlights out of that particular meeting. Second is the drought situation in Somalia, indeed, neighboring countries as well. The Horn of Africa is undergoing some difficult season with drought, which is impacting very negatively on the work that we are doing in public health. It is introducing new challenges when we try to do COVID-19 vaccination. It is introducing new challenges when we try to focus on improved testing. It is providing new challenges when it comes to the public's response to the initiatives that we are supporting Somalia and other Horn of Africa countries with. So it is a dire situation that the relevant agencies are addressing. And as Africa CDC, we are providing them with all the technical support they need when it comes to public health. And we are looking forward to the drought easing and the population settling back into a more routine way of life so that we can be able to expand our health security work in the Horn of Africa.
All right, thank you very much. Let's move on to James Chege, who is with Reuters in Johannesburg. He says, Dr. Ouma, could you give an update on the plans to secure COVID-19 vaccine orders from South African pharma company Aspen's factory? In July, the Africa CDC said it was in detailed discussions with buyers to generate demand for Aspen's COVID-19 vaccine, Aspenovax.
Thank you, James. Indeed, those discussions continue. We have not reached a breakthrough yet, and that is why we have not announced something to the public at this stage. But we continue to have very close discussions to try and unlock the situation where the manufacturers on the continent are not receiving any orders for COVID-19 vaccines. As we do that, we are also encouraging all the other countries that have ambitions for vaccines manufacturing to broaden the types of vaccines that they are going to manufacture. And we are glad to see many countries taking that on board in their planning so that we don't end up with a glut of COVID-19 vaccines, while other vaccines are actually also being required to be used here on the continent. So that's the situation. We've not reached an end, but we are encouraging countries with ambition for manufacturing to diversify the products that they would be manufacturing in their facilities.
All right, thank you, Ahmed. Paul Adepoju has two questions. The first one is, I'd like to know the Africa CDC's position regarding wild polio virus, considering that cases continue to be imported. Then the second one, he says the WHO Director General has pledged continual support for the Africa CDC. What are the updates regarding improving relationships on both ends?
Thank you, Paul. Let's start with the polio, the wild polio issue. This is a very grave public health concern that wild polio will be popping up in different parts of the world, including where it is not expected to pop up. And indeed, when samples of different sewers are made around the world, it tells us that we need to respond very effectively to the polio, the wild polio virus risk. Any presence of wild polio anywhere in the world is a huge risk to the achievement that we've already made in eradicating, well, we had made in eradicating polio. And as Africa CDC, our position is that we need to ensure that all those who need to be vaccinated are vaccinated. Second, we need to put in place surveillance mechanisms that will be able to respond quickly when a case is identified. And thirdly, it is our position that polio is not a regional or a country problem. Polio remains a global problem, and we need to address the current popping up of cases across the world in similar fashion together, so that we can be able to keep polio eradicated rather than a wild polio popping up from one place to the other. The Director General of WHO, Dr. Tedros, many of you may not know, was one of the key champions of the setting up of Africa CDC. During his tenure as a Foreign Affairs Minister of the Federal Democratic Republic of Ethiopia, he's the one who moved the motion for Africa CDC's statute to be passed by the Executive Council and then forwarded to the Africa Union Assembly of Heads of States and Government to establish formally the Africa CDC. So he's been a champion of Africa CDC for a very long time. In his current role as a Director General, we have worked very closely with his office and his colleagues, both in the African Regional Office and the Regional Office for the Eastern Mediterranean region in Cairo, to ensure that the gains that we've made as institutions continue to be protected by the two organizations working very closely together. Most recently, we were together in Lomé on Monday, and the position is still the same. Indeed, we are looking forward to holding even more joint activities so that it becomes clearer to everyone that these two organizations, Africa CDC and the World Health Organization, are on the same side of history, on the same team, and indeed addressing the same health security challenges. We are working very well together, and if there are any differences in opinion, we resolve them like professionals internally. And Paul, rest assured that what you're going to be seeing in the days and months and years to come is going to be very close collaboration between Africa CDC and WHO at all three levels: national, regional, and the global level.
All right, we have Esther Nakazi now, who has her hand up. Esther, good morning. Please go ahead with your question.
Good morning, Win, and good morning, Dr. Ahmed. Thank you for taking my question. Dr. Ahmed, now that we know that we are almost sure that Ebola survivors, Ebola infections, persists among survivors, what are Africa CDC's recommendations to countries that have these people in terms of, what are your recommendations around survivors of Ebola and maybe other viruses like monkeypox? Thank you.
Thank you very much, Esther, and for that very timely question. And not just for Ebola, I agree with you, it is for all pathogens, whether it is viruses, whether it is bacteria, whether it is other parasites. When we study the persistence of viruses within the human being, then we are able to prepare better for containing any subsequent outbreak that may result from an individual who had been infected before. So three things that we are really, the message that we are passing is in three steps. The first is one of passing understanding to the communities. What does it mean to be a carrier of a particular pathogen? And how does one deal with their status in case they are carriers? And this goes across many different diseases, including Ebola. This is important, so the message is passed. That way, when we engage with individuals like that and they have good knowledge, they don't feel like they have been targeted in a particular intervention. Second is effective treatment for those who are found to have a particular illness. The treatment being so effective that they don't become reservoirs. It is not automatic that everyone who has Ebola or any other virus or bacteria will become a carrier. So our understanding of the disease leads us to treat effectively so that there's no reservoir situation in any particular individual. Third is continued research. Although there are some indications that there may be human carriers as a reservoir, what we've still not studied closely is where else do we have reservoirs so that we can be able to protect the population better. And that's why this particular case in the DRC that has happened a few days ago is very curious to us because it is directly connected with one we thought we had brought under control 2 years back. So understanding the reservoirs, both in humans and outside of the human population, is important for us to be able to have longer time control. So Esther, the solution here is information, 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 whether it is coming from research, whether it is going to the public, or whether it is going to the policymakers, so that all of us and each one of us does the right thing in ensuring that we do not spread the virus further. But for the individuals that may be found to have long-term survival of viruses in their systems, it is information that should be provided to them carefully as they undergo full treatment so that they clear out the virus from their system. We don't want human beings to be reservoirs for any disease and any disease condition because of the way that we engage and interact. Any reservoir in a human being will then result in continued infection in a community, and that is not the ideal. Thank you.
All right, thank you. We don't have any questions or anyone waiting to ask a question, but perhaps more are still coming. And in the meantime, you have spoken about the vaccination for COVID-19 and the discussions ongoing to make sure that perhaps they are integrated into national vaccination programs. Does that then mean that the vaccination of COVID-19 will be mandatory, or will it still remain optional?
No, thank you, Wayne. The vaccines mandate, making it mandatory, has not yet been, that decision has not yet been taken. Integrating COVID-19 vaccination into the regular vaccination programs in a country, into the regular immunization programs in a country, does not necessarily suggest that we mean it needs to be mandatory. However, when we study the spread of COVID-19 virus, the reality is there are populations that are at higher risk than others. For example, if you have a crowd of people in a small space, then they're at much higher risk than if you have a crowd outside and they are spaced out. So we do encourage our policymakers to make it mandatory for example, those who are going to attend meetings where people will be in close contact. They need to mandate vaccination in that situation, because it is a defined group of people who can be able to be informed of the vaccine mandate and they take it. Second is travelers. Now, it is mandatory for you to either have a COVID-19 vaccine or a COVID test before you travel. So this again is a defined group of people that can be able to be given the information and they comply. For the general public, we are leaving this to member states to be able to make that call. But we as Africa CDC are encouraging that we should do everything that is within the rules, regulations, and laws of a country to get as many people as possible to be vaccinated so that we can avoid a situation where a new variant may be able to bring us problems in as far as new infection, breakthrough infection is concerned. So we do not yet have any policy around vaccine mandates, but we encourage policymakers at country level, those who are organizing meetings, do everything you can to ensure that those who are coming to your facilities, to your meetings, to your functions, are vaccinated, because that avoids serious illness and death. But vaccine mandates have not yet, that decision has not yet been made with.
All right. Judith Akolo, who's with the Kenya Broadcasting Corporation, says, my question is about the outbreak of swine flu in Nakuru in Kenya. Is the Africa CDC aware of this, and what is being done about it?
Thank you, Judith. You may have come a little late. It was the third outbreak that I gave a brief on today. Yes, we are aware of the outbreak of influenza H1N1, what you're referring to as swine flu, in the Nakuru County of Kenya. And we are working with the government to ensure that we contain that particular outbreak before it causes any further suffering and death. So yes, we are aware, and we are working with the government to provide relief to the health system there as soon as is practical.
All right, we have Paul Adepoju. Paul, good morning. Please go ahead with your question.
Good morning, and thank you very much. So I have two questions. Since it has been a couple of weeks now since monkeypox was declared a public health emergency of international concern by WHO, and in your update today, you said vaccination has still not started in Africa. So my question is, what has changed that you can talk about between when the declaration was made and now regarding response in Africa? And if I may also add is, being in the midst of stakeholders in Africa's health sector at Togo. What difference do you think is we now have regarding discussions around health? And are they promising? And what do you still think still need to be a more top priority regarding health discussions in Africa? Thank you.
Thank you. Thank you very much, Paul. Since the declaration of monkeypox as a public health emergency of international concern, we have seen distinct differences in the way that we are engaging internationally, in the way that governments are responding here on the continent, and in access of certain resources that we didn't have access to. So there is a distinct change since that declaration. It is not at the level we would want, but there is certainly a change, and that declaration did provide us with the avenues of taking some of the conversations we had started last year to the next step with our partners and friends of Africa. So there has been a change because we have access to more resources, not as much as we want, but we have access to more resources. Governments are responding better, and the international community is working together much more closely than the period before the declaration for a public health emergency of international concern was made. However, as things change, the speed is not commensurate with the urgency that we see on the continent. We still don't have access to enough test kits. We are working on increasing that. We still don't have access to any vaccines, and that is a big concern. And we certainly do need a coordinated international response, just like we have a very well coordinated continental response here in Africa. We need a coordinated international response where more is being put on the table to support the control of monkeypox as an outbreak of international concern. Now, second, the discussions in Lomé. I must admit that I was there for a short while, only 2 days, and the discussions have continued. But the little that I participated in, two very important things are clear. African ministers have fully understood that they are responsible for the public health space here in Africa. And they're being a lot more assertive than they were before in providing solutions that are African in nature and that are going to provide support to those of us who are working within the public health space. So that realization is very clear. Second is the need for prioritizing what is the priority. Because before, what was being prioritized is what had resources. So if a partner came and they wanted to implement program X, then you'll find many countries taking that up because it had resources. But today, it is very clear from the ministers that they are prioritizing what is a priority. And this is a very big change from what we had several years back. So I'm really, really excited that the whole vision, the whole principle of the Africa's new public health order is playing out beautifully amongst our policymakers, especially health ministers and heads of states. And we are looking forward as Africa CDC to continue to provide support for the full implementation of Africa's new public health order. Thank you.
Thank you very much, Ahmed. It's now time for you to give us the summary, main points that you want colleagues to really focus on from the briefing today.
Thank you, Wayne. And two things that really I would like us to take away from today's briefing. The first is that as we continue with the pandemic, the acute phase is done, but the pandemic continues. As we continue with the COVID-19 pandemic, we have other serious outbreaks that are happening on this continent. And I would want to encourage our colleagues in the media, fellow professionals, wherever you may be, that it is important to highlight all those outbreaks because it provides a complete picture of the serious nature of the health security situation on the continent of Africa and the need for expanded resources, especially technical resources here on the continent. And you see, today we have shared 6 different outbreaks, one that is new, the H1N1 in Kenya. We are at risk of many more such outbreaks, even though we continue to deal with the COVID-19 pandemic. So let us highlight each and every outbreak as a potential pandemic so that we can be able to arrest it quickly and effectively. Second thing that I would like to come out of this meeting today is that the COVID-19 pandemic is evolving, and it is time for us to begin thinking of strategies that are going to ensure that our vaccination rates are not only climbing to 70%,